Hello, and welcome back to our clinical case series. I hope you've enjoyed what you've seen so far, and we're going to jump into some more clinical cases. So stick with me here along this journey. Lots of clinical cases to discover. Today's case we're going to talk about is a localized periodontal defect on tooth number 14. Have you ever ran into these types of defects with furcation bone loss and not sure what to do? Well, here's the way that we treat these cases here at Arcadia Perio. So sit back, relax, and let's dive in on tonight's presentation. So, three main learning objectives that I want you to learn and walk away with tonight from tonight's quick lecture. I want you to be able to assess the clinical indications for LANAP in moderate to advanced periodontitis and be able to interpret 2D radiographs and three-dimensional imaging. Is three-dimensional imaging recommended for advanced periodontal defects around teeth? I would suggest so. I'm going to be able to characterize the defect in morphology and the disease severity. I want you to be able to describe the LANAP protocol step by step. I'm going to be able to describe it in your own words so you can tell the patients what's going to happen when they come and see me to get their periodontitis treated. I want you to understand everything step by step, including the laser settings, the sequencing, and any adjunctive measures that correlate to expectations in hard and soft tissue changes. And finally, for this case, this is a case that's been followed up for 2 years. This patient recently came in March of 2026 with a 2-year follow-up with periapical imaging and CBCT imaging. A really well-documented case that shows the power of regeneration with a laser-generated blood clot. I want you to be able to assess outcomes. So when you're looking at these x-rays, you know how to explain to the patient, look at what happened. Look at how much bone was regenerated in between the tooth roots. All incredible stuff. So first, it's important to note the electromagnetic spectrum, right? Different lasers in dentistry do different things based off of the wavelength of light and where that light energy is absorbed. We aren't going to talk about other lasers tonight. Today, we're just going to really focus in on the wavelength of light for the Periolase MVP-7. What wavelength is that? It's 1064, right here. We are in the near infrared spectrum of light. And why is that important? It's important because that light energy is absorbed into pigmentation. Well, you might say, well, why is that so important? Well, remember, the red complex, your Porphyromonas gingivalis, Tannarellus forsythia, those bacteria have pigmentation to them. Those bacteria have penetrated deep into the surrounding tissues, deep into the dental tubules, and well beyond that pocket into the osseous structures. Remember, that light energy is going to selectively remove all of that infected and inflamed tissue, and it's going to eradicate the bacteria. Super important. This is why this laser wavelength of light works so well to treat periodontal disease. So just understand, it's important to understand where we're at in the electromagnetic spectrum. We aren't going to talk about erbiums or CO2s or anything of that nature, even diodes. Not the point of the lecture. I want you to hone in on the infrared, near infrared, 1064 wavelength of light. So we just mentioned this. So let's take a look at this chart and let's draw on this chart so you can help understand what we're talking about. So let's draw a line straight across at 10 to the 0. So we're talking about the x-axis here. So anything below here, it's not absorbed. Anything above the x-axis is absorbed. So notice here when we're talking about the wavelength of light, we're right at 1 micron or 1,000 nanometers. So if we go up this line right to here, look at this spot right here on this x and y axis. Where is that light energy penetrated and absorbed at 1064? It's absorbed into melanin and hemoglobin, aka pigmentation. So now you know why the laser selectively removes the pathogenic bacteria, but it leaves behind all of the healthy tissue. Super important. What does that mean for our patients? It means you're going to heal super quick, right? My scalpel blade cannot differentiate between infected and inflamed tissue and healthy tissue. When you cut, you remove excess tissue. So there's no longer any cutting with this laser, right? It's selective removal of all of the bad stuff. It's awesome. So now let's talk about, not only have we talked about the wavelength of light, where it's selectively absorbed, but now I want to talk about the depth of penetration, right? The NDA laser penetrates well beyond the laser tip. It's going to penetrate 4 to 5 millimeters beyond the laser tip. And remember too, the light is divergent when it comes out of the laser tip at 13 degrees off center. So a divergence in total of 26 degrees. So when I am running that laser around an infected pocket, I only have to get to accessible depth. I don't have to get that laser tip all the way to the bottom of the pocket. Why? Because remember, that light energy is divergent, so it's getting into the adjacent surrounding tissues, it's going into the dental tubules. It is selectively removing all of the bacteria, all of the disease and infected tissue, but also too, remember, it's going to penetrate well beyond the base of the laser tip. So that's how we're able to treat these infected teeth so effectively. So I want to take a moment and I really want to walk through the different steps of LANAP, right? Laser assisted new attachment procedure. When I'm talking about LANAP, I'm talking about a full mouth disease protocol treated in one sitting. When I'm talking about laser assisted regeneration, I'm still using the Periolase MVP-7, but I'm doing it in site specific areas. So let's walk through this schematic here and let's talk about these steps individually so it helps you better understand what is going on when we treat periodontal disease at Arcadia Perio. So step one, or figure A, are bone sounding probe depths. Why is this important? Because this helps me calculate the total amount of energy needed to treat the disease. As the pocket numbers increase, more energy is needed. In step B, we are going to selectively remove all of the diseased tissue. Now remember, when we talk about laser settings, all lasers are different. So remember, the laser is called the Periolase MVP-7. Why is that important? Multivariable pulse duration, meaning there's 7 different pulse settings that will allow me to titrate the laser to effect, right? So, and the other thing too is when we're using the laser, there's different power settings in terms of when the pulse durations are different. So the peak powers are different per different pulse duration. So even though the average power may be 3.6 or 4 watts, when I'm at 100 microseconds, remember when my foot is on the pedal, the laser is still off about 99.8% of the time. So if my peak powers, if my pulse durations are super short, my peak powers are really high. So the amount of energy per pulse delivered at 100 microseconds is about 1800 watts. At 150 microseconds, it's about 1300 watts. And it goes down proportionally after that. So for the ablation, the selective removal of all the diseased tissue and the eradication of the bacteria, this is going to be on a shorter pulse duration. If the tissue is a little bit hemorrhagic in nature, it might be 150 or 250 microseconds for the pulse duration. But if the tissue is coral pink without much heme, you're going to be more at 100 microseconds. But that's how you titrate your first pass. In figure C, we are going to remove and debride all the root surfaces with our piezo ultrasonics, a set of 3 different piezo tips used in a sequential order to remove all of the subgingival plaque and calculus. In figure D, we are going to do our blunt dissection and bone biomodification. What does that mean? I'm going to make the bone bleed. I'm going to stimulate it. I'm going to get it excited. Why? Because then I'm going to get the body to release its own stem cells. Why is that important? Because now I'm going to use the regenerative potential of the stem cells in the form of a laser generated blood clot. So in figure E, we're going to do hemostasis, not coagulation. Coagulation kills cells. Hemostasis, live viable stem cells in a gelatinous clot. This is going to be a longer pulse duration, 550 microseconds to 650 microseconds to get that gelatinous clot to form. Once the clot is formed, what we do is we do our occlusal adjustment, right? We're going to remove all those non-working interferences, any wear facets, right? It's not occlusal equilibration, it's more like occlusal triage, right? We're eradicating those areas of potential interferences. Then we let everything heal, right? We're going to let things heal for 6 months to 12 months before we go back in and reprobe this patient. In terms of osseous regeneration, radiographically, we know about 80% of the wound healing in terms of changes radiographically will happen within the first year. Within year two, about 15%. And year three is the additional 5%. So with one laser treatment, bone will continue to improve and densify for up to 3 years, as long as we account for the etiology and the occlusal trauma and the pathogenic bacteria. So you'll see in this case how bone continues to improve over time. But I want to give you a good general overview just to recap what is LANAP and what is LAR when it comes to treating either generalized periodontal disease or localized periodontal disease. So I think it's really important to highlight prognosis and how do I view teeth and how do I explain to the patient what's the long-term outcome of this tooth? Prognosis can be either, it can be identified as diagnostic, therapeutic, or prosthetic. And it can also be individual or it can be an overall prognosis. And remember, prognosis is the prediction of the probable course, duration, and outcome of the disease based off of the general knowledge of the pathogenesis of the disease and the risk factors associated with the disease itself. So this is a really good example of how I view prognosis at Arcadia Perio. Now, let's look at these two radiographs on the left. What are we looking at here? Are we looking at individual tooth-related factors? These factors may include the remaining bone support, probing depths, mobility, furcation involvement, crown to root ratio, root trunk length, tooth morphology, pulpal involvement, sinus involvement, position and alignment, right? All individual tooth related factors. So if I looked at these two teeth on the left, tooth number 15 and tooth number 30, I would say they're poor to hopeless, right? If I looked at it based off of individual tooth related factors. But that's not how we consider prognosis. When we're looking at prognosis, we're looking at with treatment, are we able to lead that tooth or that area to periodontal stability? Notice I'm not saying twos and threes, right? If it's a 10 or a 12 and it goes to a 6, that's stability. And tracking these teeth long term to making sure things are not, worsening. So what we're looking at for prognosis is, are we able to get that tooth stable and maintain the stability long term? And if we can, then it's favorable. If it's possible, then it's questionable. And if it's unlikely, it's unfavorable. So that's the way I like to look at prognosis when I am viewing teeth. I don't look at it in terms of individual tooth related factors. So let's move forward here. This is our periodontal prognosis report card by Miller and McIntyre, right? So this just gives you an idea in terms of different factors to look at across the bottom of the screen. Furcation, A1C, a systemic factor, mobility, probing depths, molar type, smoking, a social factor, and age. And you're able to categorize and give numbers to teeth. And with those numbers, so for example, tooth number 30 has a 7. So when we look over here, a score of a 7 in 15 years, there's 86% that the tooth will be there. In 30 years, there's a 66% chance. But now when you look at tooth number 8, look at the difference between we go from good to guarded. 81% at 15 years, and 56% at 30 years. So just a good tool to help you explain, hey, how likely are we to keep this tooth? Or what's the chances it's going to go? And do we want to attempt to save that tooth? Or should we just go ahead and remove that tooth at this time? These are all factors to consider using this periodontal prognosis report card as an adjunctive tool. So now that I've given you some background information, I hope that was helpful in providing a good foundational knowledge so you can help better understand this case here. This is a case that I have really enjoyed treating, and I've really enjoyed following this case up for over 2 years. So the patient presents a younger male, I think 26, 28, somewhere in that vicinity, ASA1, no systemic issues. Patient comes in for tooth number 14. However, we do a comprehensive exam. I still look at every single tooth because it's unlikely that there is only one isolated defect. In this case, that was the case. There was only the one isolated defect on the buccal aspect of tooth number 14. So let's look at the two-dimensional radiograph and the three-dimensional radiograph. So I think it's important for me to highlight what I'm seeing here in terms of the furcation bone loss on tooth number 14. It's quite advanced. We have some root resorption over here on 12 and 13 due to probably orthodontic movement. And we also looks like maybe a little bit of root resorption on the distal buccal root. When I get a case like this, I really want to look at what's the bone loss look like in 3 dimensions. So in terms of the bone loss in 3 dimensions, the buccal furcation extends all the way to the buccal aspect of the palatal root. So this is a deep grade 2 buccal furcation with a horizontal component and a vertical component. So here's what our treatment looks like in terms of with this tooth tested vital to cold. I was still questioning my vitality testing, so I even sent this over to the endodontist to further confirm my suspicion that this tooth was vital. So there is no endodontic issues involved with this tooth. So this leads me to believe that this is trauma from occlusion in the presence of either a tooth-related factor, such as a cervical enamel projection, in combination with the bacterial component, right? The pathogenic bacteria. So we're going to treat both etiologies at play, the trauma from occlusion and the periodontal infection. So we're going to treat the periodontal infection with laser-assisted regeneration, walking you through that protocol step by step. And I'm going to do heavy occlusal adjustment. In this case, I'm actually going to take this tooth out of occlusion because I want to completely eliminate the traumatic forces. So as you can see here, the tooth is out of occlusion. And now when it comes to the occlusion, we're going to grind it low and let it grow, right? I got to see what's going to happen. But if I don't control for that etiology, I won't get the ideal osseous regeneration. So in terms of the LANAP protocol, occlusal adjustment is key to success with these cases. So here we are at 6 months. I could not believe the regeneration results at 6 months. It's typically unlikely to see this much regeneration this early on. Remember, when we're going to probe at 6 months, our probe depths typically precede any radiographic changes. So just something to be mindful of. But look at the start of the regeneration into the furcation. So it appears to be bone. It looks like bone. It's resistant to probing now. That probe depth was about a 12 on the buccal, and now it's a 5, right? So things are going to continue to improve. So now I'm going to follow this case. I'm going to put this patient on a 3-month maintenance program, a strict maintenance program. We know that regardless of oral hygiene, if that patient is on a 3-month recall, according to the Michigan studies in Ramford in the early 70s, that disease progression is unlikely to continue. So compliance is huge at our office. I don't want these patients to get lost and not come in for their maintenance visits. So I really stress this at the time of the consultation. So here we are at 12 months. Continued regeneration. Probe depths are decreased down to threes and fours. That tooth is stable and healthy. So we've done a good job in terms of reversing the aging process of this tooth and bringing this tooth from an unhealthy state to a healthy state. And now let's look at it over a timeline, right? I think this slide is the most important slide in tonight's presentation. Looking at that osseous defect on the buccal aspect of tooth number 14 and continuing to watch the bone grow and regenerate and ossify and densify over time. So initial presentation 2/27/24. 6 months was back in September of 2024. 12 months was actually March of 2025 and 24 months was March 16th of 2026. So that's a typo there, but this is how good that bone can regenerate. So here's the clinical photos, right? A little bit of soft tissue recession, but look at how healthy and coral pink that tissue is. This is a huge success in my book here. So just looking at a different view again. So now we know that this tooth is stable. We know that this tooth is healthy. There's still a root proximity issue right here. Look at how close the root proximity is, that mesial buccal aspect of number 15 to the distal buccal aspect of tooth number 14. So what's next? Orthodontic consultation. We want to try and distalize this root to get a little bit more of a better embrasure form to further stabilize the area. If we can get that tooth into a better physiologic position, it's going to be more resistant to periodontal disease and trauma from occlusion. So a lot of our patients end up going through orthodontic treatment, post-LANAP treatment, because it further adds stability long term. So just to highlight and recap what happened in tonight's presentation. So hopefully now you're able to assess clinical indications for LANAP, localized periodontal defects, and generalized periodontal defects, and be able to evaluate these defects clinically with two-dimensional radiographs and three-dimensional radiographs. I hope you got a little bit more of an understanding in terms of the laser physics and why the Periolase MVP-7 works so well with the step-by-step diagnostics. And then two, now you're able to evaluate and look at things clinically and radiographically with photos, radiographs, both two-dimensional and three-dimensional, to see how these cases continue to grow bone over time. I hope you learned a little bit more about prognosis and how I kind of view teeth at my office. So thank you for really joining in on tonight's lecture, understanding a little bit more about how I treat localized periodontal defects at Arcadia Perio. Thanks again, and remember, take your 3-question quiz after this and get that CE credit sent to you here. Have a good day.